You know, if you make an incision just a fraction of a millimeter too deep on a patient's cheek, suddenly you aren't just dealing with a minor cosmetic issue.
No, absolutely not. You're looking at potential permanent facial paralysis.
And that is the razor's edge that reconstructive and aesthetic surgeons live on every single day. I mean, usually when we think about a medical diagnosis, there's a certain mechanical predictability to it, right?
Yeah, like a broken bone on an X-ray.
Exactly. It shows up as this clean, jagged white line. It's binary. It's broken or it's not. But the human face completely defies that kind of simplicity.
It really does. I mean, we look in the mirror and we see this, single unified canvas of expression.
Right.
But beneath that surface, it is a wildly complex three-dimensional topographic map. Guessing is just, it's simply not an option.
So for our deep dive today, we are pulling directly from a foundational medical text, Oculofacial plastic surgery. Specifically, we're focusing heavily on the structural blueprints that are laid out in Chapter 1.
Yeah, authored by Drs. John L. Wobig and Roger A. Daly, along with a really massive team of contributing MDs.
And if you're listening to this right now, whether you're, say, a medical student cementing these concepts for boards, or maybe a young surgical professional refining your spatial awareness, or honestly, even if you're just a self-taught learner who's completely obsessed with the hidden mechanics of the human machine.
This is designed specifically for you.
Exactly, because we want to move beyond just, memorizing anatomical Latin names. We're looking at how these structures actually behave under a scalpel.
Right, because a textbook list of tissues is totally useless without the clinical context of how they interact. A surgeon mapping out a reconstructive approach has to treat the face almost like a geological dig.
Oh, I like that. A geological dig.
Yeah, you're navigating these very distinct structural strata, and if you lose track of your depth, you're entering a danger zone.
Okay, let's unpack this. Let's actually map that dig. Because if a surgeon is planning a trajectory, they aren't just thinking skin and fat, right?
Right. No, not at all. The text actually divides the face into 5 distinct structural planes.
5 planes.
Okay.
But mechanically, how do these planes actually dictate the boundaries of a surgery?
Well, think of them as interdependent architectural layers. The outermost boundary is plane 1, which is obviously the skin.
Right. Plane 1 is skin.
Then beneath that, you have plane 2, the superficial facial fascia. Moving deeper brings you to plane 3, which houses the mimetic muscles.
And those are the muscles responsible for, like, every facial expression you make, right?
Exactly. Smiling, frowning, all of it. Then plane 4 is the deep facial fascia, which is a much tougher connective tissue barrier. And finally, you hit plane 5.
And just from a surgical standpoint, plane 5 sounds like the absolute point of no return.
It kind of is. The text notes that this deepest plane contains the facial nerve, the parotid duct, and the buccal fat pad.
Wow. So if your instrument slips into plane 5 unintentionally,
you are risking catastrophic damage. I mean, to the patient's ability to even move their face.
So that underlying risk is why surgical techniques are so strictly bound by these planes. If we connect this to the bigger picture, every surgical technique relies on respecting these exact boundaries, right?
Absolutely. If a surgeon is performing, say, a superficial skin lift, they want to stay well above plane 3. You do not want to traumatize those mimetic muscles.
Makes sense.
But if they're doing deep reconstructive work, they have to meticulously separate plane 4 from plane 5 just to protect that facial nerve. Every single layer has its own tensile strength, its own vascular supply, and its own threshold for trauma.
Okay, so since every surgical incision has to start at the outermost boundary, let's talk about plane 1, the skin.
The largest organ?
Right, though not the heaviest, interestingly enough.
Yeah.
But we all know it provides this physical barrier against infection. But from a surgical mechanics perspective, the way the epidermis, the outermost layer, operates is wild.
It's fascinating.
It's not a static sheet of material. It's basically a hyperactive assembly line.
That's a perfect way to put it. It's an integrated epithelial layer that completely overhauls itself under a very strict biological clock.
So when you look at the epidermis under light microscopy, you don't just see one uniform block of cells.
No, you see 4 contiguous zones, and they represent different stages of a cell's life cycle. It all begins at the base, which is predictably called the basal layer.
The proliferative compartment.
Right, the birthplace of the keratinocyte.
Yeah.
So these skin cells divide and multiply at the very bottom.
But they don't stay there. As new cells are born, the older ones are physically pushed upward into the next zone, which is the spinous layer.
Yes.
And this is where the mechanical engineering of the face really starts to show. The text mentions spiny projections spanning the spaces between these cells, What is the actual utility of those spines?
So those spines are ultrastructural anchors. They're known as desmosomes.
Desmosomes, okay.
Basically, they're cellular bridges. If you think about the daily trauma a face endures, rubbing your eyes, sleeping on a rough pillow, scratching your cheek, there's a massive amount of shear force applied to the epidermis all the time.
Right, constantly.
Without those desmosomes binding the keratinocytes tightly together, just the simple act of wiping away a tear would literally shear the outer layer of your face right off.
Oh, wow. So they aren't just loosely stacked bricks. They're laced together like, I don't know, microscopic chainmail? Or like industrial Velcro to resist shear force?
Exactly. Like Velcro. If you're rubbing your eyes right now, you are actively stress testing those exact desmosomal connections.
That is wild to think about.
And as those heavily anchored cells continue their upward journey, they enter the third zone, the granular layer.
Which the text says is incredibly thin, right?
Yeah, usually just 2 to 3 cell layers deep, but it performs a critical function for, well, surgical recovery and environmental protection. The cells here participate in cornification by releasing lipids fats into the intracellular spaces.
So the factory line is basically spraying a layer of waterproofing mortar over the cells.
Waterproofing, yeah, and barrier enhancement. Those lipids prevent excessive water loss from the body, and they stop external fluids and pathogens from easily penetrating the tissue.
So it creates this intracellular cohesion for the final outermost stage.
Right, the cornified layer, also known as the stratum corneum.
And this is the part of the epidermis we actually interact with. This is what we touch. And mechanically, this is kind of the graveyard of the assembly line, isn't it?
It is. The desmosomal anchors, that Velcro we talked about, they finally dissolve, and the dead keratinized cells shed off in a process called desquamation.
But here's the critical surgical takeaway from the text. This entire process, from birth in the basal layer to shedding in the cornified layer, takes roughly 12 to 14 days.
And that 14-day clock fundamentally dictates postoperative care.
How so?
Well, if a surgeon places a non-dissolving suture in the epidermis and leaves it there for 3 weeks, that cellular factory doesn't stop. The basal layer keeps producing cells, the spinous layer keeps anchoring them, and the epidermis will physically grow over and swallow the stitch.
Oh, wow. So that's how you end up with permanent track mark scarring.
Exactly, because the tissue reorganized itself around the foreign body.
Which means a surgeon isn't just managing the cut. They are actively racing against the biological clock of the patient's cell turnover.
Yes. And the margin for error is incredibly thin. Quite literally, depending on the geography of the face. The text specifically notes that this outermost cornified layer is at its absolute thinnest on the eyelids and the genitalia.
So that structural reality completely changes the instrumentation required in oculofacial surgery.
Completely. You cannot treat the ultra-thin, delicate epidermis of the eyelid the same way you'd treat, say, the skin on a patient's back or scalp.
Because it just can't handle it.
Right. The eyelid simply cannot handle the same tension, the same thickness of suture, or the same aggressive handling. If you pull too hard, those delicate desmosomes tear, and the tissue necrotizes.
Okay, before we move deeper, while we're hovering in the epidermis, here's where it gets really interesting. We have to address a major biological misconception that the text clarifies beautifully.
Ah, the melanin discussion.
Yes. When discussing the epidermis, skin color and melanin naturally come up. And I'll admit, there is a common assumption out there, even among people who have studied some biology, that a patient with very dark skin must simply possess a higher concentration of melanocytes.
The actual cells that manufacture pigment.
Right. People assume darker skin equals more melanocytes compared to a patient with very pale skin.
And the clinical reality is entirely different. The text is definitive on this. There are absolutely no significant differences among human races in the number or the anatomical distribution of melanocytes.
Wait, really? None at all?
None. To understand skin pigmentation from a histological perspective, you have to look at the epidermal melanin unit.
An epidermal melanin unit. So
yeah,
we are looking at the functional relationship between the cells rather than just doing a head count.
Exactly. One single melanocyte is in physical contact with approximately 36 surrounding keratinocytes.
Okay, 1 to 36.
Right. The melanocyte acts as the manufacturing center. It produces melanin inside tiny packages called melanosomes. It then distributes those melanosomes outward and upward into the 36 surrounding skin cells of that unit.
Oh, I see. So the difference in skin color has absolutely nothing to do with the number of manufacturing plants.
Not at all.
It is entirely determined by the production volume of those plants. how widely they ship the melanosome packages, and how long those packages remain intact inside the skin cells before breaking down.
You've got it. Darker skin is the result of increased melanin production, broader cellular distribution, and longer retention of the pigment. It is a difference in metabolic function, not cellular quantity.
That is fascinating. But why is that so important for a facial surgeon to know?
Because understanding that function is vital when considering post-inflammatory hyperpigmentation. Any surgical incision causes trauma. And in skin, with highly active epidermal melanin units, that trauma can send melanin production into overdrive,
Resulting in really dark, highly visible scars.
Exactly. The surgical approach has to account for how those specific melanocytes will react to the scalpel.
Okay, so if the epidermis is this hyperactive, constantly shedding 14-day assembly line, it's mechanically useless for anchoring a heavy surgical stitch, right?
Yeah, completely useless. If an oculoplastic surgeon is trying to lift sagging facial tissue, a thread is going to rip right through that microscopic chainmail.
Right, so the scalpel has to seek out a load-bearing structure, which forces the surgeon to descend into the second major structural plane of the skin, the dermis.
The structural foundation. If the epidermis is the weatherproofing on a house, the dermis is the structural framing and the internal plumbing.
And the dominant mechanical component here is collagen, specifically type I and type 3.
Yeah, and the dominance of type I is staggering. It accounts for roughly 80% of the total collagen in human skin.
80%.
Yeah. But the dermis isn't just a solid block of uniform biological concrete. The collagen architecture actually changes depending on how deep you go.
Right, the text divides it into two highly distinct histological regions. The superficial zone, resting right beneath the epidermis, is the papillary dermis.
Where the collagen, predominantly type 3, is thin and randomly arranged, it forms a loose network.
So it's kind of like scattered light insulation packed into the ceiling. It provides some structure, but it remains flexible.
Exactly. But as you move deeper, you enter the reticular dermis. This is where the heavy lifting occurs.
The load-bearing beams.
Right. The collagen bundles here are coarse, thick, and crucially, they run parallel to the surface of the skin.
And that parallel arrangement is what gives the skin its sheer strength. When a surgeon is closing a deep wound under high tension, they are anchoring their heavy sutures deep into those parallel bundles of the reticular dermis.
They have to. That is the only tissue dense enough to hold the face together against the mechanical pull of gravity and muscle movement.
And that dense reticular framework also houses the critical hardware of the skin, doesn't it?
It does. The dermis is highly vascularized and innervated. It contains the blood vessels that supply the epidermis above it, the lymphatic channels, and the sensory nerves.
It also houses the epithelial adnexa.
Right. The skin appendages, your hair follicles, your sebaceous glands producing oil, and your apocrine and acrine sweat glands.
Okay, but looking at the mechanics of the face, collagen provides tensile strength, basically the resistance to pulling.
Mm-hmm.
But what gives the face its elasticity? Like if you stretch an eyelid, it snaps right back into place. Is that the collagen bundles acting like rubber bands?
No, actually, collagen is more like a tow cable. It prevents overstretching. The snapback is provided by an entirely different protein, elastin.
Elastin. Okay.
But what constantly surprises medical students is the volume. Elastic fibers make up only about 3% of the dry weight of the dermis.
Wait, just 3%? That seems almost impossible given how pliable human skin is.
I know.
That tiny fraction of tissue is doing an immense amount of mechanical work every time we smile or frown or blink.
It really is a highly efficient, highly localized protein network. But structurally, you can't just have rigid collagen cables and elastic rubber bands sitting in a vacuum. There has to be a medium that supports them, something preventing friction and absorbing trauma.
And that medium is the ground substance.
Yes, ground substance.
Which I'll admit, ground substance sounds like a really generic placeholder term.
Right.
But structurally, it acts like a biological shock absorber?
It does. It's an amorphous, complex gel composed of water, electrolytes, plasma proteins, and mucopolysaccharides.
And those mucopolysaccharides are essentially complex sugar molecules that are incredibly hydrophilic, right? Meaning they trap and hold water.
Exactly. So they create a hydraulic cushion. If the collagen bundles are the wooden beams of a house, the ground substance is the fluid matrix surrounding everything.
It buffers the cells, keeps the structural proteins hydrated.
And it facilitates the movement of nutrients and waste between the blood vessels and the tissue.
And clinically, The ground substance is what a surgeon is interacting with when they inject local anesthesia, isn't it?
Yes, exactly. When you push fluid into the tissue, it is the ground substance that expands and swells to accommodate that volume. Understanding how this matrix absorbs and disperses fluid is critical for managing post-operative edema or swelling.
Okay, so we've mapped the scalpel's journey through the superficial planes. We breached the 14-day cycle of the epidermis, sliced through the random fibers of the papillary dermis, and bypassed the parallel load-bearing beams and hydraulic ground substance of the reticular dermis.
We've gone pretty deep.
But the face isn't just tightly wrapped skin over bone. It has contour. It has volume. Which brings us to the underlying fat layers.
Right. As you exit the dermis, you enter the subcutaneous fat. This is the primary padding of the face, but its distribution is highly variable.
It's thickest on the cheeks, the temples, and the neck, providing those soft, rounded contours associated with youth.
But mechanically, this fat can't just be a loose, liquid pool of lipids. Otherwise, gravity would immediately drag it all down to the jawline.
Right, it has to be physically compartmentalized. And the text describes connective tissue septa, these fibrous structural walls that divide this subcutaneous fat into organized lobules.
Those fibrous septa act like a biological honeycomb. They trap the fat into distinct pockets and anchor it to the overlying dermis and the underlying fascia.
So when a surgeon is performing liposuction or a superficial lift, they're navigating and manipulating these specific septal compartments.
Yes.
But, and here's where it really matters for our focus, the anatomy of the face, particularly around the eye, has a hidden trapdoor.
Yeah.
For an oculofacial plastic surgeon, the subcutaneous honeycomb fat isn't the whole story.
Not even close.
The deeper you go, the rules of the architecture change entirely.
They really do. What's fascinating here is as you move beyond the subcutaneous layer, passing through the superficial fascia and the mimetic muscles, you discover a second, entirely different plane of fat. This is the submuscular non-septate fat.
Non-septate, meaning it completely lacks those fibrous honeycomb walls dividing it into neat little lobules.
Right. It's a continuous, deep pad of tissue. And the most critical structure in this deep plane for any mid-face or eyelid surgery is the SOOF.
The SOF, the suborbicularis oculi fat.
Exactly. If we break down the terminology, sub means beneath, and orbicularis oculi is the sphincter-like muscle that encircles the eye. So this is the fat pad lying deep beneath the eyelid muscle.
And its precise geographic location is what makes it so vital. The text identifies the SOOF as a supraperiosteal fat pad, meaning it sits right on top of the periosteum, the dense membrane that directly covers the actual bone of the zygoma, the cheekbone, and the maxilla of the upper jaw.
It is the absolute foundational support column for the midface. As we age, gravity and tissue laxity cause the midface to descend. The cheek drops, the nasolabial folds deepen, and the support beneath the lower eyelid just hollows out.
Right.
For decades, early cosmetic procedures attempted to fix this simply by pulling the superficial skin tighter.
Which creates that artificial windblown look, because you're basically pulling the weatherproofing of the house to try and fix a collapsed foundation.
Exactly. You can't disguise a structural deficit in the submuscular plane by putting tension on the epidermis and dermis.
Which is precisely why modern oculoplastic reconstructive surgery prioritizes the SOOF. If a surgeon is performing a lower blepharoplasty, an eyelid lift, or attempting to reconstruct the midface after trauma, they must surgically locate, elevate, and secure the SOF.
By repositioning this deep, non-septate, supraperiosteal fat pad, the surgeon restores the actual structural volume of the cheekbone, which in turn naturally supports the lower eyelid above it.
It perfectly illustrates why a surgeon has to be a master of the 5 planes. I mean, if you stay too superficial, your aesthetic results will fail mechanically.
And if you go too deep carelessly, you hit plane 5 and risk the facial nerve. It is an intricate, high-stakes navigation of human topography.
Well, we have traced this architecture from the microscopic desmosomal velcro of the epidermis, down through the parallel load-bearing collagen beams of the reticular dermis, navigated the honeycomb compartments of the subcutaneous tissue, and finally arrived at the deep skeletal foundation of the SOOF.
It's just a phenomenal biological machine. And for anyone entering the medical field, internalizing this gross anatomy is the non-negotiable prerequisite to everything else you're going to do.
Right.
You cannot manipulate wound healing, control scar formation, or safely execute a surgical intervention if you do not fundamentally respect the mechanical properties of these individual layers.
Which means we need to make sure these concepts have actually locked into place. So to deliver on the educational focus of this deep dive, we are going to throw a rapid-fire review scenario your way based on the exact mechanics we just unpacked.
Consider this your clinical pop quiz. To reinforce what you've learned today, ask yourself, you are an oculofacial surgeon preparing to make an incision directly on a patient's eyelid. Based on the histological geography we covered, which specific layer of the epidermis must you actively account for because it is at its absolute thinnest in this exact area of the body, demanding ultrafine instrumentation?
Think about the final stage of that 14-day cellular assembly line, the outermost boundary.
The correct functional structure is the cornified layer, or the stratum corneum. Because it is so incredibly thin on the eyelids and the genitalia, the margin for shear force tearing is virtually non-existent.
If you visualize that dead keratinized layer, you are already thinking like a surgeon navigating the microscopic topography. But we want to leave you with one final provocative concept to mull over before we close the book on Chapter 1.
Yeah, we spent a lot of time discussing the relentless 12 to 14-day turnover rate of the epidermis, the migration from the basal layer all the way up to the shedding of the cornified layer. Think about how that rapid, unstoppable cellular replacement process doesn't just dictate how skin flakes off. It fundamentally controls how a physical wound seals itself, how it heals, and how it eventually leaves a scar.
It is the biological timer ticking away the moment the scalpel makes the first cut.
So consider the broader implications. How might a deep mechanical understanding of that exact 14-day timeline fundamentally change the way a surgeon schedules a patient's post-operative care?
Oh, that's a great question.
How does knowing the exact speed of cellular migration dictate the precise optimal moment to remove a suture? Ensuring the wound is strong enough to hold together, but acting just before the epidermis permanently grows over the thread and ruins the aesthetic outcome.
It really transforms gross anatomy from a static list of Latin names you memorize for a test into a living, breathing, constantly rebuilding ecosystem that you have to actively manage. Thank you for joining us on this deep dive into the blueprint of the face. Keep questioning the structural mechanics of the world around you, and we will catch you next time.